Ladies and gentlemen, welcome to the American Healthcare Association and LeadingAge teleconference on nursing home reform. At this time, I'll turn the call over to Beth Martino. Beth, go ahead.
Good morning, and thanks to everyone who has joined us for our call this morning. We all appreciate your time. We're excited for our announcement today. I'm going to go ahead and turn directly to introducing our panel of speakers this morning, and then we'll get going. So we have joining us this morning Mark Parkinson, who is the CEO of the American Healthcare Association and National Center for Assisted Living, which represents more than 14,000 nursing homes and assisted living communities around the country. We have Dr. David Gifford, who is our Chief Medical Officer at AHCA NCAL. We also have joining us Katie Smith-Sloan, who's the President and CEO of LeadingAge, the Association for Nonprofit Providers of Aging Services, including nursing homes. And we have Carol Silver Elliott, who's the President and CEO of the Jewish Home Family and Chair of the Board of LeadingAge, who's the Association for Nonprofit Providers of Aging Services. And so with that, I will turn it over to Mark Parkinson, the President and CEO of AHCA.
Hey, thanks, Beth. And I want to thank all of the media outlets that have taken the time to cover what we believe is an exciting and important announcement relating to a joint venture, a joint proposal from both LeadingAge and the American Healthcare Association. The Cares for Our Seniors Act is, we think, a bold approach to improving care in facilities and hopefully minimizing the possibility of what we've seen over the last year. The last year, the COVID pandemic has been by far the greatest tragedy in the history of the skilled nursing profession. In just one short year, hundreds of thousands of our residents have been infected with COVID. And unthinkable, over 125,000 residents and staff members have died as a result of COVID. The human loss it's simply unthinkable. As tragic as it has been, it is not our intent to blame anyone for this event. When you look back at the spread of COVID, it becomes very clear that the fault of COVID is not on the frailties of any human beings or any acts of omissions. Instead, we have been dealing with a once-in-a-century type virus, a virus that spreads by asymptomatic carriers, so it successfully circumvented all of the normal procedures for infection control. As a result, it wasn't just bad buildings that got COVID and good buildings that didn't. In reality, virtually every provider in the country ended up with COVID. And we saw this in congregate settings across the globe, not just in nursing homes. We saw it in assisted living buildings. We saw it in universities and boarding schools, and even in convents. The COVID virus is just a very virulent virus. This does not mean, though, that we can't make improvements. It doesn't mean that we should just say, well, this is just one of those things that happens. Let's get past COVID and go back to business as normal. Instead, we owe it to the 125,000 people, residents and staff members and their families who have died as a result of this, to really deeply examine what happened. And is there anything that we can do to minimize the possibility of this in the future and actually get better in care as we come out of the pandemic? And as we've analyzed it, we've come to two obvious conclusions. The first is that when residents in long-term care facilities are not prioritized, very bad things happen. In the early days of the pandemic, when there was virtually no PPE and no testing available to long-term care facilities, tens of thousands of people died that didn't need to die. That's because they were not a priority. The second thing we learned, though, is a positive thing, and that is that when our residents are counted as a priority, good things can happen. And that's what's happened with the vaccination program. The CDC recognized and the governors agreed that long-term care residents should be at the absolute top priority, and look at the results. The results speak for themselves. The number of new COVID cases in buildings has declined dramatically to almost a level of 0, and deaths have declined as well. The obvious conclusion is that it is time to place the residents of our facilities at a top priority, not just when we're in an emergency. but in ordinary times as well. And that's what the Care for Our Seniors Act is all about. It does two very bold things. First, it says, yes, there are things that we can do to get better. As we spent the last months analyzing what are the clinical suggestions that have been made that would actually work, we have concluded that some of them could move the needle. And those are things like a 24-hour RN requirement in every nursing home across the country, enhanced infection control preventionist in every building across the country, and a requirement that a 30-day supply of PPE must be stored at all times. There are many other exciting things that we are proposing that Dr. Gifford will outline in his presentation. But the second thing that we recognize is not just that we need to have these additional requirements placed upon buildings, but we have to figure out a way to support the buildings themselves. For too long, states have underfunded the Medicaid system, resulting in a very fragile financial structure for providers. Hundreds, but perhaps thousands of buildings are actually operating at a loss, and the COVID pandemic has only exacerbated that. This proposal not only calls for providers to step up with the care in their buildings, it calls for policymakers to step up and put providers at the priority level that they should have been all along. And it does so by enhancing the FMAP at the federal level and by requiring states to fund long-term care at an adequate level through Medicaid. We think that these two very significant and bold proposals together can materially move the needle of care within our buildings. I'm very excited now to introduce Katie Sloan, who is the CEO of LeadingAge. We've worked closer during the last year of the pandemic than we have during my entire 10 years at AHCA, and it's been a terrific working relationship. And I think it's a real sign of the action that needs to be taken, that the two associations have come together to offer this proposal. Katie?
Well, thank you, Mark, and thank you all for being with us today. You know, you're right that this has been a tragic year of unprecedented challenges for everyone working in and living in nursing homes. Many of the mission-driven, not-for-profit nursing home providers that LeadingAge represents have been deeply embedded in their communities for more than a century. They have stood the test of time. And they tell me that battling the pandemic has been the fight of their lives. Nursing homes were ground zero of the crisis, and our older, more frail residents were a primary target for the virus. But the sad truth is that the fragile state of long-term care in this country is nothing new. COVID has exacerbated the challenges providers have been facing, too often on their own, without adequate federal support. The issues magnified by the pandemic, from a broken financial system to a struggling workforce, are the same ones that we have been talking about for years. For decades, in fact, our nation has undervalued and underinvested in older adults and their care providers. The result? Older adults and those who care for them bear the unfortunate consequence. The suffering brought on by COVID's unprecedented threat has reinforced the urgency of addressing these issues now. The federal government estimates that nearly 27 million people will need some kind of long-term care by 2050. Our vision is a future in which that enormous group of Americans have access to excellent quality, person-centered care delivered by quality staff in a place they call home, a setting of their choice that reinforces their dignity and their well-being. To make this future a reality, our society and its leaders must commit to reimagining at least one of these settings, nursing homes. We've said it for years, and now is the time to make fundamental changes in the financing, regulation, oversight, and practice of long-term care. And every one of us has a role to play. The policy recommendations we're sharing today are an important and immediate first step. Each recommendation on its own will make a difference to the urgent needs of older Americans and their care providers. Together, they are the starting point for creating a better system in which all nursing homes can be bastions of quality care and quality of life. This is what older adults and their families deserve and should expect. Reform must begin by helping care workers, those essential professionals who provide the majority of care in nursing homes. Caring for older adults in nursing home requires not only specialized understanding of their health care and functional needs, but also a dedication to the quality of their life. Nursing assistants are professional caregivers who provide that intimate, hands-on care that is essential to long-stay nursing home residents. Yet these workers are too often undervalued, undercompensated, and offered limited career mobility. So it should come as no surprise that recruitment and retention are among the most pressing challenges confronting nursing homes. We know that nurses and nurse aides are among the fastest growing occupations in our country, but the supply is not keeping pace. That's a real problem when we rely on them so heavily to be excellent care providers, companions, and partners with the residents they support. So now is the time to work together on a new approach to investing in this essential workforce, including government funding and support initiatives. Foundational to any reform of aging services is fixing chronic Medicaid underfunding. Properly funded, Medicaid must be dedicated to improving care by supporting our workforce and quality service delivery. It's fundamental to good stewardship of the federal and state money we are entrusted with. We've long known that Medicaid reimbursement isn't consistent with the costs of delivering quality care in most states. Reimbursement only covers 70 to 80% of actual costs. That's a gap that we must fill if we are to achieve our goal of ensuring that those who need nursing home care have access to the highest quality care. The clarity provided by the tragedy of COVID has created the most important moment in a generation to seek fundamental nursing home reform. Change won't happen overnight, but we must ensure that policymakers deliver the resources needed as transformation begins. The proposals we're releasing today are the right start. So now I would like to turn it over to my colleague, LeadingAge's board chair, Carol Silver-Elliott.
Thank you, Katie. As a way of background, I will tell you, as president and CEO of the Jewish Home Family, we represent a continuum of services for older adults located in northern Bergen County, New Jersey. And our geography, 300 yards from the New York border, really put us in a position to get to know COVID up close and personal in ways that none of us ever wanted. My role here is not only to support change and policy, but to tell you what it felt like from the perspective of a provider on the very, very front line of this from the end of March onward, at a point in time where we knew nothing, at a point in time where we had no testing, no PPE, no information, and no support. When we first became aware of COVID, we began to prepare as best we knew how, but even at that point in time, we didn't have the information that we needed. When we first received people who turned out to have COVID from the hospitals had no testing. When we called our laboratory provider, they offered us 5 test kits for 800 people that this organization serves on a daily basis. What were we going to do with 5 test kits? Like all of us, we figured it out. And we figured it out because of the incredible efforts of our team, because of the extraordinary work that long-term care workers provided across the country. Our folks come to work every day because they believe in our mission. They believe in the ideals. They believe that we exist to not just keep elders safe, but to really provide them with an enriched and fulfilled life. And we saw day after day those examples playing out. When we saw staff from our finance department coming in to deliver meals, when we saw our nurse, Ellison, whose father died of COVID, whose mother had COVID. He and his sister were very ill, and he came right back and said, I have a mission to fight this virus. I have a mission to save people because I couldn't save my own father. We saw it in people like Gabby Moskowitz, who as a dietitian was concerned with the fact that people were not eating. And she told a story that will forever resonate with me about an elder with COVID who wouldn't eat, couldn't eat. She called her daughter and said, "What is it that your mom will always eat?" And she said, "Chocolate ice cream." And Gabby tried to feed this woman chocolate ice cream, and she tried again, and the woman refused it. And she thought, I'm going to let this ice cream melt, and I'm going to come back. And when she came back and helped her drink the melted ice cream, she drank it all. And every 2 hours, Gabby came back, and she drank this melted ice cream from her. And 2 days later, she walked in the room, and this elder was sitting in her bed eating a chicken dinner, believe it or not. We saw our rehab team walk into rooms to do turning and repositioning, things that they hadn't done since they were in therapy school, because these were things that they could do to make a difference. Story after story after story on the front lines. And yet, we all experienced, as I experienced, standing at the bedside of beloved elders, watching them fight for breath, sometimes losing that battle. COVID has made a major impact on all of our organizations, but also on all of us who care about older adults, who work for their well-being, who fight for their rights, who want them to live full lives and want them to have the opportunities that they so richly deserve. Older adults are not a problem to be solved. They're not a diagnosis. They are individuals who are entitled to care and services and respect and have so much to offer us. Through these policy changes, these are ways that we can continue to support these older adults and continue to do the work that is so important and so much needs to be done. Thank you for listening to us today, and thank you for the opportunity to share with you from a provider perspective. I'm now going to turn it over to Giff.
Dr. Gifford, I think you're on mute.
Thank you. As you've heard from the three previous presenters, that this virus really has been devastating to the residents, to their families, and to the staff. It is going to change them forever. And as we look at it, this virus clearly has exacerbated and revealed some of the longstanding issues and some new issues. As Mark said, the priority issue, and I think as you've heard clearly just described, when we're not a priority, bad things happen. So we've gone back and looked at what are the things that we think could not only help with infection and pandemics, but also can help overall and really address this changes in long-term care. As Mark said, they fall into 4 areas: clinical enhancements, workforce retention, better oversight, and changing the structural setup of our buildings. Under clinical enhancement, we have 3 proposed areas. One is to enhance the infection preventionist. We want to make sure that it's not a one-shoe-fits-all approach, because we know that a 300-400 bed facility needs more than one infection preventionist, yet a 20-bed facility in a rural area may not need a full-time infection preventionist. It needs to be adjusted based on the number of residents, the acuity of the residents, the diagnoses, and what the relationship they have with the hospital partners. We know all staffing is important, but research consistently has shown a relationship between registered nurse hours and outcomes. And so we are supporting a 24-hour registered nurse in the buildings. But to do that, we need to have incentives and to make more nurses available and be willing to work in the facilities. And then I think it's clear that not only is infection control outbreak for pandemics, but we're going to continue to have outbreaks. We have multi-drug resistant organisms spreading from hospitals to nursing homes. We need more PPE. And we don't want to be in a situation where we're caught flat-footed again. So we're supporting a 30-day supply of PPE. This requires, though, clearly having the resources to both have access and a priority to get that, and the resources to purchase that PPE, because the expense of PPE has gone up tremendously. On workforce retention, we heard loud and clear for several years before the pandemic that finding and retaining staff was one of the greatest challenges in long-term care. We've testified before Congress, we've asked for help. We're coming back again and saying this must be a priority. Staff are hard to find and retain. We need incentives to bring staff in. Direct loan forgiveness to the staff, tax incentives to the staff so that they will stay and come into the long-term care is critical. Subsidies to universities, colleges, and technical schools to train more people is critical, but it must be linked with having those individuals working in long-term care. Otherwise, they get snapped up by hospitals and other healthcare providers, and we're still left not as a priority. The closure of schools during the COVID also revealed the incredible need for childcare assistance. And we really need childcare assistance to help with people coming into work in our sector. We need to improve the oversight. It is clear that the survey system is broken. I think everyone complains about it. We have consistently seen the same citations over and over again without necessarily improvements. Somehow we've lost our way. We now base the effectiveness of the survey system not on its mission, which is to ensure the safety and well-being of the residents, but on the number of citations, how many citations are written up on time. It's become very bureaucratic and it's moved away from the residents. We need to have a shared responsibility and a shared goal of getting everyone back in compliance and meeting the issues that are there. Not whether the citations are given out, how many CMPs are given out. Those are important tools, but they need to be tools that are used to achieve the end goal that is out there. And then also, there is the issue of chronically poor performing facilities. We recognize that there are facilities that year over year continue to have problems. Continue to do the same thing and expect a different outcome is not the right way to approach that. Those facilities need to have an in-depth evaluation about what has led them to be chronic performing facilities, and then a meaningful plan put together to turn them around. If they can't meet that plan or it's not viable, then the options need to be pursued with either new owners or managers or potentially closure of the facility. And then I think we heard loud and clear in many news stories and from many around there that family members and residents' voices are not always well heard and captured out there. We fully support and have supported for a number of years collecting satisfaction and information both from families and from residents and making that publicly available. We desperately, I think, need that now more than ever before. And then lastly, it's clear that our buildings were built 40 and 50 years ago. They need to be updated, and we need to move and transition to single rooms. That is not easily done, and we need to look at how do we move from double rooms to single rooms. What is the resources it takes? How's the time frame to do that? And we would support that movement, because we know that not only do single rooms have a better infection control spread in buildings, but also it improves the dignity and the privacy of the residents that are there. That is our package. I think it is comprehensive. It touches on clinical, workforce, regulatory oversight, and the buildings. There certainly may be other issues that are out there that one could argue, but I think this would have a meaningful change for the residents and meaningfully change long-term care as we go forward. With that, I'll hand it back to Mark.
Hey, thanks, Giff. And I want to thank all the other presenters for, I think it's really some compelling presentations. And Carol, your presentation was phenomenal. And to hear what you've gone through in your building, it's inspiring, but it's also reflective of hundreds of thousands of other frontline workers across the country that have had the same sorts of experiences. The Care for Our Seniors Act is really an exciting thing. If we can get to the point that we can have this enhanced infection control, RN coverage, PPE, a more collaborative survey process, and a real attention to poor performers and improving their performance, or just finally reaching a point where they can't run buildings anymore, all of these things together can make a major difference in the care of our long-term care residents. All of these things, though, have a price. And they have a price at a time when the skilled nursing sector is already teetering. MedPAC does an annual report every year, and even before the pandemic, it showed that the all-in margin for skilled nursing facilities was basically zero, and that thousands of buildings across the country were already underwater. The pandemic has just made it worse, and as many researchers have indicated, one of the realities that the pandemic has exposed is the fractured financing system of long-term care. And it specifically relates to Medicaid. There are a number of states across the country where the policymakers have made the conscious decision to underfund Medicaid and to underfund the cost of care. Unfortunately, that has a real impact at the bedside. The residents in those states simply cannot get the level of care at the quality that they need. This proposal and all of the things that we have put together to improve care cost in our estimate about $15 billion a year. An unfunded mandate of $15 billion on an already fragile sector would put thousands of buildings out of business. To simply propose these things without paying for them would be irresponsible. As a result, we've come up with what we think is an innovative funding proposal that would finally require the policymakers to place residents of these facilities at the priority that they belong. In a nutshell, it calls for a couple of things. First, it calls for the federal government to increase the federal match for the skilled nursing benefit so that every year the federal government would send additional dollars to the states specifically for skilled nursing. It also requires the federal government to develop a definition of allowable cost, so that the government is finally saying, instead of 50 different definitions of allowable cost, we'll have one. And then it requires the states to fund a large percentage of the providers in their buildings at break even of those allowable costs, not at a profit, but at a break even point, so that providers do not lose money in providing the Medicaid services that these residents need and that they deserve. Collectively, with both the clinical changes and the financial changes that we are proposing, we believe and know that this will dramatically improve the quality of life of the people that live in our buildings. And that's why we are so excited to announce this today and hope that Congress and the states will embrace this and learn from the lessons of this tragedy so that we don't ever have to face a year like we faced in 2020 and 2021. And with that, Beth, I'll turn it back to you for any questions that we might have.
Great. I think our moderator may jump in for just a moment to give instructions to the folks on the call about how to submit questions.
Yes, the Q&A pod is now open. You can go ahead and type your questions in the question and answer pod.
So our first question comes from the Chicago Tribune, and I will turn it to Mark because I think it follows on from what you were just speaking to. Can you just address how much you think this will cost and where you think funding will come from, particularly Medicaid funding, PPE, nurse training, and facility renovation?
We think that the total cost of the proposal is about $15 billion. About $11 billion of that are in the major clinical suggestions that we've made. The additional RN hours, the additional employees for infection control, developing a stockpile of PPE, et cetera, is in the $11 billion range. Another $4 billion is the part that would address the long-term underfunding of states to their Medicaid system. So we think all in all, it's about $15 billion. The funding mechanism is that the federal government would increase the match for the SNF benefit by about $15 billion. That money would then flow to the states. The states, though, couldn't siphon it off to other projects, which has happened in the past, whether the money is spent on highways or any other thing. Instead, the states would be required to pay most providers their allowable cost to a break-even point. So the money comes from the feds to the states. The states are then required to spend it to the providers. The providers are then required to spend it on the clinical suggestions that we've made in the proposal.
Thanks, Mark. Our next question comes from Lauren with CQ Roll Call. And Katie, I will turn to you maybe to kick us off with an answer to this question. She asks, any nursing home legislation will likely spark conversations about broader reforms that some lawmakers are interested in, such as pass-through wages, star rating reform, transparency in corporate ownership structures, etc. What will your message be to lawmakers as those conversations happen?
Sorry. So thank you. I mean, I very much see this set of proposals as the beginning of a conversation about a number of other issues that impact nursing homes. We do need to have a conversation about wages. We do need to have a conversation about oversight and transparency. And we look forward to having those conversations.
Mark, I'll turn the next one to you. It comes from Maggie Flynn at Skilled Nursing News, and she actually has a two-part question. First is, are there any requirements around transparency of ownership and ownership structure in our proposals? And second, what requirements would AHCA and LeadingAge support for operators around the use of increased federal match, should those come through?
Sure. So, and I'll have Giff confirm this, but I don't think we addressed the transparency issue in this proposal. We are not opposed to any legislation or any proposals as they relate to transparency. This specific proposal is focused on how do we improve care at the bedside. And so we really looked at the clinical type suggestions that had been out there, whether it was RN hours, infection control preventionists, et cetera, and really didn't look at some of those ownership type issues. But historically, AHCA, and I'll let Katie speak for LeadingAge, historically, AHCA has supported transparency. We're fine with it. We feel like we have nothing to hide, and we're happy to, whatever folks want to put on the 5-star report or anywhere else on who owns the buildings, we're completely okay with that. The second question relating to how do we make sure that the states spend the money on the nursing homes, is that the question? Beth, could you give me the second part of that? Just repeat the second part again.
Sure. So the second part of her question is, what requirements would AHCA and LeadingAge support for operators around the use of an increased federal match?
Sure. So what our proposal does is it passes this money on to the states then pass it on to the operators. The operators are required to do these things. These are not suggestions that we're making in this proposal. And we're not suggesting that people have 24-hour RN or full-time infection control preventionists. It's being mandated. They would be required to spend the money on those things. Now, as Giff indicated in his discussion, it doesn't necessarily mean that there would be one infection control preventionist in every building. There are 800 bed buildings in New York State where you need more than one. There are 30 bed buildings in Kansas where it doesn't make sense to have a person full-time. So it's more related to the size of the building itself, but there would be significantly more infection control preventionist and RN hours under this proposal. It would be mandated by the proposal, and so the providers would be forced to spend the money on it.
Let me just add a word about transparency, because I think that was part of that question. LeadingAge has long endorsed full transparency. And the reason we do is because it's absolutely crucial to establishing a productive and a trusting relationship between nursing homes and care providers, residents, families, and the government. So it's essentially that we look at solutions towards transparency.
Yeah, I mean, I wish that they would pass the transparency proposal just to get this issue off the table. It is a distraction from the quality issues. There's this view that, oh my goodness, if we just knew who owned all these buildings, things would get better. That's not going to improve things. So but we're happy to do it. Let's get that information out there. But the real work that needs to be done is in terms of providing care within the buildings.
Thanks, Katie and Mark. Our next question is coming again from Lauren with CQ Roll Call. And Katie, I could start with you on this, and similar to our prior question, perhaps then Mark could weigh in. So The question here is, would LeadingAge and AHCA be supportive of a reduction in Medicare reimbursements to help pay for higher Medicaid rates?
Well, that sort of goes to the heart of how nursing homes, the business model for nursing homes right now, which is, the Medicare that covers the short-term rehab and Medicaid, which covers the long-stay residents. And it all depends on what the resident mix is in any given nursing home. Two separate pots of money, two separate authorizations from the federal government. It's actually sort of hard to imagine how that would actually happen.
Yeah, I would agree with Katie. I mean, one of the challenges of the Medicaid underfunding is it's put enormous pressure on the Medicare system. It requires associations like LeadingAge and AHCA to every year continue to get increases through Medicare because the Medicaid underfunding is so dramatic. Right now, it wouldn't make sense to cut any rate. I mean, we're still feeling the impact of the pandemic and the long-term survival, actually the short-term survivability of many buildings is in doubt. But if, in fact, we could receive our full Medicaid cost, and with that proviso, then it would be possible to look at the Medicare rate. But right now, we're not receiving anything close to our full Medicaid cost, and so the Medicare payments are absolutely essential to keep these buildings going.
Can I just jump in on that from a provider perspective for a second? In my organization alone, we estimate that Medicaid is $200 less than cost every day for every person. We're in our 180 beds, we're 45% Medicaid. That's a significant loss. So yeah, Medicare does make a difference for us because that skilled nursing load not only is an important part of balancing the budget for us, that short-term rehab load, but also, quite frankly, is what people need. We have a lot of people who can't live quality lives if they don't get that intensive rehabilitation. So yeah, if one thing moved, could the other one potentially adjust? Possibly. But right now, to impact that's like, borrowing from Peter to pay Paul, but all told, everybody loses.
So that looks to be our last question. As we wrap up, I'll just put out a final call. If anyone does have additional questions, please feel free to put that in the chat. And unless anything else pops up there, I do want to thank all of our panelists for your time today, and appreciate your remarks, and we'll be following up with anyone who has additional questions. So thank you all very much. Enjoy the rest of your week.
Ladies and gentlemen, thank you for joining us today. You may now disconnect.